Okay, good afternoon, everyone, and thank you very much for being there. Each one of you is highly appreciated because I think you have made special effort to be in this hall. Otherwise, post-lunch session halls are usually vacant, and also this happens to be the last session of the day. We will be talking about avoiding and recovering from Bleb failures in trabeculectomy. So trabeculectomy, we know, is the commonest procedures that we do, and this is still kind of the mainstay of glaucoma therapy. But unfortunately, there's a significant failure rate with this procedure also, and very often we get into trouble. So idea of this instruction course is how we can avoid, how we can make our results better, and also if something is not right, how we can kind of rescue from that position. So we have with me, I have faculty, very well-known faculty, Dr. Sushmita Kaushik. She's professor of ophthalmology at PGI Chandigarh. I'm Dr. Pandav. I'm also from the same place. Dr. Parul Pujani is with us. She is professor of ophthalmology at Government Medical College, Chandigarh. And we have Dr. Faisal with us. He is, again, a lot of glaucoma experience. He is associate professor with us at PGI Chandigarh. So what we want to basically, the course layout is that I'll be speaking about glaucoma surgery, why it fails. I think very important to understand the basic mechanisms, so we'll touch upon them briefly, and what kind of our hypothesis is about the surgical failures, and how we can do trabeculectomy, so that it succeeds and it doesn't fail. So what are the steps that we need to take? Then what are the risks for surgical failure, and when would you and how do you take care of them? And then we also have to take care of identifying failing Blebs. And then finally, I will talk about the how to rescue if the Bleb has already failed. So Dr. Faisal has to go, so you want to take your after my talk? Yeah, okay. So there's going to be a little bit change in the schedule, but he has a presentation in the other hall as well. So why glaucoma surgery fails and what is the current understanding? So this surgery was done, this is second post-operative day, and there are two different eyes done by the same procedure, same surgeon, and identical procedure basically. And I'll ask you which surgery you think, they look very similar to, but what is your guess at this point of time? Can you say the Bleb A and Bleb B, which one you think is going to do better? Is there any clue, or can you predict? Who says A is better? Raise your hands, please. No, anyone for the B? B is going to be better? Okay, so I see more hands in favor of B. Maybe some clue there. To me, they actually look identical. So let's fast forward to day 7, and this is how the Bleb looks at day 7. Now you can see in the in the Bleb A day 7, you can see some vascularization is happening. B has not shown much activity, in that area. So what is your take now? How many of you think the Bleb A is better or do better? One. And how many of you think Bleb B is better? Again, more number of hands for the Bleb B. So this is what happens 8 weeks down the line. So look at the Bleb A and look at the Bleb B. So they actually started very identically. Everything is identical. Post-operative care is identical, but something goes wrong in one Bleb than the other, and it's very hard to predict. So Bleb A was actually an excellent Bleb. This is the kind of ideal Bleb we want: diffuse, low-lying, normal vascularity and good IOP control, and B has become a tenon cyst. So, but if you look these Blebs carefully, you would find that there are clues in that, which could perhaps predict, which Bleb is going to do better. So if you look at normal wound healing, so that actually brings us to why the Blebs fail. So in the normal wound healing, we have a coagulative phase, we have inflammatory phase, scar formation and then the wound remodulation. And if you can see from the graph, most of the fibrosis actually goes up steeply around day 7. And after that, day 14, there's not much of a change. After that, actually is a modulation, but this is a normal wound. And in trabeculectomy, this path is not followed. And this is quite more complicated because in trabeculectomy, what we have tissue trauma, we have foreign body, and we have aqueous flow. So if there's only tissue trauma and foreign body, the wound actually heals very quickly, but it's the aqueous which creates problems. So we try to understand what happens in the aqueous, what that aqueous do, and we replicated a rat eye model for glaucoma surgery. And what we found that the pro-inflammatory cytokines like TGF-beta, they are actually consistently and markedly elevated and for a very long time. So in mouse eye, it took almost 7 days for them to come down, but equivalent to the human eye would be perhaps 7 to 10 weeks. So that means the wound healing is not actually stabilizing in human after glaucoma surgery for at least 2 to 3 months. And this is the anti-inflammatory panel. That means the cytokines which are good, which will help your heal, have a lesser scar. So they are actually reduced, their expression is reduced, and their expression is delayed, by almost 1 week, 1 to 2 weeks sometime in rat eyes, and in our human eyes probably the similar time. So what we understand is the presence of aqueous increases expression of these pro-inflammatory cytokines like TGF-beta, and it inhibits or delays the expression of anti-inflammatory cytokines. So that's what kind of complicates the wound healing. So again, the problem, then we try to understand what does aqueous actually do. So we set up another experiment. Here we looked at the role of the aqueous in how it is influencing our wound healing. And if you look at that first bar, that's kind of an experimental bleb where no fluid is flowing through it. It's just a bleb created by a device. And you can see the bleb is actually quite porous. The aqueous flows through, when we test it, is very porous. But if you let the aqueous flow through the implant or the bleb, it reduces within 4 weeks. Actually, the porosity goes down 80%. And these blebs, they have a very thick wall, the blebs which are exposed to aqueous, and the blebs which are not exposed to aqueous have very thin and porous wall. So that means the aqueous is actually doing something there. And we know that there are cytokines in the aqueous like TGF-beta which would complicate. But however, if we remove the aqueous and we just use BSS instead of aqueous, similar things happen again. So that means aqueous is there, but there is other things as well. So what this means is that aqueous cytokines may be responsible for blood failure, but the balanced salt solution has similar effect. And so that probably there is a kind of a fluid stress is happening in the blebs, which is contributing towards capsular thickening and failure. And what we believe that capsular thickening might be actually a secondary phenomenon. Blood actually starts failing much before that. So this is our model of pathophysiology of blood failure. So normally, after surgery, the blood should heal within, and the capsule should stabilize within 4 to 6 weeks. But what happens when you switch on the tap and the fluid start flowing through it, those cytokines are reactivated, or they kind of the healing process is interrupted and it gets very prolonged. And then there you have a proliferation of the fibroblast. They get converted into the myofibroblasts, and subsequently they contract, the bleb becomes small and thick-walled, and IOP goes up. And when the IOP goes up, the fluid stress increases again. So this is a vicious cycle which kind of ends with the bleb failure, so unless you interrupt it some way. So how we can interrupt this vicious cycle, that's important. So number one, you can restrict fluid into the bleb. So that means immediately after surgery, it's better to have a tight closure in the first few days at least. Still some wound healing has happened, and too much of flow is not really required. We use anti-inflammatory that we all know to cut down on the inflammation. We use anti-fibrosis, mitomycin C. However, we do not know what is the exact timing should be for the mitomycin C. We are using on table, which to my mind is too early, but we don't know what is the best time to use mitomycin C. We have tried anti-VEGF. There are some studies where anti-VEGF has been used in glaucoma surgery with good results, so there's a role for that perhaps. and also the keep IOP low. And there's now evidence, at least in from our implant experience, that if you keep the IOP low in the early postoperative period, they do better in the long run, and that probably would be true for the trabeculectomy as well. So thank you very much, and I'll invite our next speaker. I think I will go to Dr. Faisal first for his talk. If you have any quick questions, you can actually ask. And any quick questions, you can take 1 or 2 questions. All right, Dr. Faisal, please.
So very good afternoon, everybody. I thank AIOS and Professor Pandav for inviting to this wonderful IC. So I will start my talk as how to identify a failing blebs. So even the time of mushrooming of multiple mixed surgeries, trabeculectomy with MMC is still the gold standard. We all like to prefer trabeculectomy as a first-line procedure in most of the cases. So even in a well-experienced man, the long-term success of the primary trabectomy is ranging from 57 to 90%. So what we would like to get an ideal bleb that is like moderate height, normal conjunctival vascularity, and posteriorly flowing diffuse bleb, and no leak at surgical incision, well-formed AC, and target IOP. But often we get pictures like that, maybe scarred or cystomant or thin cystic leaky avascular bleb. So how to identify before going to this stage? So bleb failure can happen at any stage of after the surgery, maybe very early stage itself, or in the early, like within 1 week to 2 weeks, or in the intermediate, maybe after 2 weeks to 6 weeks, maybe late in months to years. So in the very early stage, one should have signs of the excessive hyperemia, very low or hypotony, and the excessive vascularization. These have the major signs in the very early stages. So the excessive hyperemia means there is more vascularity, and the more what happens with more vascularity, it will inhibit more of the fibroblast and more of the inflammatory cytokine, which leads to early fibrosis and failure. And one should find out the various causes for the early low IOP of hypotony, because the hypotony lead to less flow through the subconjunctival space, causes mechanical adhesion or early wound healing. Then further on, if you even increase the IOP, the bleb won't lift it up. So one should roll out the bleb leaks or any other alternative pathway for echoes, or any conjunctival wound leak or at the surgical margin, or at inadvertent conjunctival injury, or any other. In this page there is a conjunctival leak here and suprachoroidal, there is a serous choroidal also. One should build up the IOP as early as possible to a normal level. Then what will happen? The early rise in IOPs are already discussed. But there is if the IOP rises, that causes the mechanical as well as the and also what are the reasons for an early build-in IOP. So one can have to look at the iris plugging or look at this bleb. Though there is much highly vascularized bleb, even in there is a encystment or the fibrosis started here within a week itself. So one should find out what are the reasons for high IOP, then treat the IOP and lower the IOP to a normal level. So, sir already told high IOP initial 1 to 2 weeks, one should be taking care of with anti-glaucoma medication or any treatable pathology. Should treat with the maybe go for surgical to relieve the iris block, or the maybe nodo 5FU or bleb needling. So next sign is the small bleb. You should assess the bleb size. The small bleb may be due to restricted posterior flow, and careful assessment of the scleral flap often forgot here, because in the early stage one won't expect the fibrosis around the scleral flap. So even if the conjunctiva is loose or mobile, one should slightly gently palpate the periscleral area with the patient's lid itself. So if you don't get a smooth feel or hard wooden feel, then you should think about there is fibrosis started around the flap area, that is around the flap margin. So then the next is I already told about the other features like encapsulated bleb. The first picture I already told, the first week itself the encapsulation has started. In the second picture there is 2 weeks post-operatively, there is encapsulation already started. So you have to think about these causes along the reduction in IOP if the IOP has raised up. So then encapsulation can happen later also, in the intermediate to late phase also. Like this case, this around this around 6 weeks, this is also around 6 to 8 week time, this encapsulation has started and the IOP started rising slowly. So these are the major signs like IOP, the fluctuations in the very low IOP or high IOP postoperatively, or the hyperemia, vascularity, and the blood size, and the cyst formations. One can have this like ring of steel formation because the fluid confined into the particular very localized area. Then there is addition between the conjunctiva and sclera peripheral to that. That's lead to a ring of steel appearance. All the fluids are going to here only. So one need to tackle this reason as early as possible to get a outcome later on. Very late sign may be like flat bleb or like a scarred bleb like this. One should have to tackle these changes. One to identify very early these changes. So, and very thin and avascular bleb is also risk for failures because this indicate that there is avascularity necrosis and the poor functioning of the bleb also. So there are imaging techniques also one can do like UBM or ASOCT. In a normal functioning bleb like a thick hyporeflective with multiple intrastromal cysts, whereas a non-functioning bleb look like more hyperreflective with low or without any microcystic changes in the stroma. So early detection and timely intervention is important to identify the failure, and various signs I already described, and to have to tackle these according to these signs, how to treat the why the bleb has going to fail, also treat at the time.
Thank you, Dr. Faisal. Any questions to Dr. Faisal, because he will be leaving the hall. Any questions? I think what Dr. Faisal has tried to show is that blebs can fail in very different ways and at different times. We are mostly concerned about the immediate post-operative failure because we want the trap to succeed, and if the trabeculectomy works for the first 3 months or so, then the chances are that it's going to work later also. But that's not always true because these blebs keep on evolving. In fact, trabeculectomy blebs never heal. We say the wound heals, but if you look at it, the trabecular blebs, they actually never heal in that sense because something is always going on there. The fibrosis, which has at first there is a vascularization, inflammation, then you have then the scar is formed, and then there should be a remodeling of the scar. So the remodeling keeps on happening, and that that is always there. So sometimes you see the blebs fail late, and sometimes we also see in the late hypertony can also happen. This, for some reason the fibrous tissue becomes thinner or apoptotic because the apoptosis goes away, and the trabeculectomy, which was functioning normally, actually start functioning like more. Sometimes that also happens, but commonly there's a fibrosis which leads to increase in IOP. In the initial period, like Dr. Faisal mentioned, I think the important signs are that the inflammation, the vascularization of the bleb height, and the IOP. So they actually give you a good clue that you need to do something. You need to modulate these blebs so that they function better. And normally we are using mitomycin C, and we expect that the blebs should be pale looking or avascular, and if you see a little pale, like I think when I showed you those pictures, the B bleb that was actually looking less vascular at 7 days and even later, and that was also a little pale in the center. So we are we have that understanding that bleb should do better, but not always. What happens is that the pale bleb actually indicates that there's a less of vascularity there. So that means there's a relative ischemia there. So if you have a bleb which is becoming pale early in your post-operative period, that means that bleb is actually ischemic. So if you have bleb which is ischemic, that will produce VEGF-like, and that will induce vascularization. But because now we have treated that bleb with the mitomycin C, the vessels cannot really grow into that area. So the vessels, they will grow in the periphery. And when they grow in the periphery, they'll produce a fibrovascular elements, they lay down the fibrovascular bundles in the periphery of that blister which is forming. And that is what I think Dr. Faisal referred to as the ring of steel, and we also call this a ring of steel is formed. So how the ring of steel is formed? That's formed because the vessels cannot grow to the central area because there's a mitomycin induced inhibition there. But there's a more production of the VEGF, so more vessels are coming in. So they are stopping at some point, and that point becomes your barriering of steel. So that's how these Blebs fail. Thank you, Faisal, for your presentation. We'll go to the next, Dr. Sushmita. So Dr. Sushmita is going to tell you how to do trabeculectomy for a successful outcome.
So at the outset, thank you very much, Dr. Pandav sir and AIOS for the opportunity. So trabeculectomy is still our savior, and it saves vision because the vast majority of our patients come with advanced disease, they're poor, and they're unable to afford medications. And despite all the tom-tomming of the MIGs that we see around us, I think it's very, very important for every one of us to know how to do a good trabeculectomy, because believe me, that will save vision. So this is a patient I've pulled out, somebody who came to us almost about 10 years ago, and he presents. So these are what patients present as. Split fixation, 10-2 fields almost gone, 0.9 cups, and the OCT is completely gone. So nothing but a trabeculectomy is going to work. And this is 9 years after a phaco-trab in both eyes. And you can see these are the pictures, the visual fields when he came to us, and these are visual fields now. So pretty much we've been able to preserve whatever vision he has. The pressures are fine and the fields are stable. So at the end of the day, when we're really doing glaucoma, it's about preserving and saving whatever vision that the patient came to us with. So the success, as we've seen, depends on preoperative, surgical procedure, and post-op nurturing of the Bleb. I'll be dealing with the preoperative and the surgical procedure, and the post-op nurturing, I think sir will take on. So in the pre-op considerations, we'll touch upon to assess ocular surface and conjunctiva, avoid anticoagulants, lower the pressures before entering the eye, and a mannitol pre-op for vitreous detergents. And during surgery, it's nice for adequate exposure, minimize bleeding, careful dissection, adequate size and thickness of the scleral flap, that's important, and iridectomy to encompass the sclerectomy, no intraop hypotony at all, reasonably tight closure of the scleral flap with releasable sutures, and a watertight conjunctival closure. So this, in a nutshell, would be what your pre-op and intraop would be. So let's look at them a little more carefully. So we need to assess the ocular surface, the lids, adnexa, conjunctiva. It's nice to give topical steroids a week prior because all of them have been on multiple anti-glaucoma medications usually, and it's a very inflamed sort of surface. Reduce the IOP before surgery, stop anticoagulants, and of course assess the general health. So eye on the right, if you're going to go in straight away, it's going to be very difficult to control the pressures with the trab, whereas I would like to operate with the eye on the left after a short course of 10 to 15 days of steroids and make it quiet and then go in. Another way to look at this is to assess the conjunctiva. You can see we are really going down and seeing the movement of the conjunctiva under the sclera. It gives you an idea of whether it's mobile or whether there has been already subconjunctival fibrosis. When you know, probably you can up the dose of your anti-fibrotics if you do that. The other thing is an adequate exposure and conjunctival flap. So these are just small clips which will go on. This is a corneal traction suture, which we usually use. We have to have an adequate exposure no matter what. There is also an ong speculum, which is on the lower side, and you can see you don't need sutures then. It has a larger inferior blade, which just pulls the eye down, and you can see that there is adequate exposure. The next thing to do, of course, is to have a conjunctival flap. The phonics base needs lesser dissection, so we've all shifted to a phonics based. I'll just move this forward. Yeah, so we've all shifted to a phonics base rather than a limbus base simply because the dissection required is lesser and we have adequate space to make the scleral flap. We avoid cutting the tenons because that causes a lot of bleeding, so you'll see most of us usually push the tenons away, which makes it better. The next, of course, is to make your partial thickness scleral flap and mitomycin. So it's nice to cauterize the bleeders, just lightly. Be sure that you're not going in with a bleeding subconjunctival space because that will make it more difficult. Whether you do a triangular or a rectangular flap is a matter of surgeon's choice. Ultimately, it doesn't matter. What matters is you need to dissect at least 2 millimeters into the cornea so that when we make the incision, we are sure that to include the limbus. MMC, this is Penkhor's technique. We put it right away at the fornix and see that the edge of the conjunctiva is not used. 0.2 to 0.4 milligram per ml for 2 to 4 minutes, depending on the case, and it's put right up there and wide application in the fornix, avoiding the limbus, which we think by avoiding the limbal stem cells, you have lesser incidence of cystic blebs. The next would be a paracentesis and sclerostomy. So the interesting thing about paracentesis for a trab would be that it's a long tunnel and usually parallel to the limbus rather than go straight in, and that is especially important for phakic eyes to avoid injury to the lens. We usually do give pilocarpine to constrict the pupil and put in a bit of viscoelastic to avoid the hypotony. Coming to the sclerostomy, we can use either. This is just using, sometimes you don't have a punch if you have 2 or 3 glaucoma surgeons in the same OR. So using scissors and Avana scissors is fine as long as your iridectomy is covering the entire sclerostomy so that there is no block later. The scleral flap closure usually is with releasable sutures, so you can use any technique. The idea is to have a tight closure so that the inflamed aqueous does not go out into the subtenon space in the early period. You don't mind the pressures being in your higher teens just for about a week or so. And there can be any technique to do the ong. I like to do the shoelace pattern, but any technique to do the releasable sutures as long as you have a bite or a loop on the cornea, which you can take out at the slit lamp postoperatively. Then, of course, you need a watertight conjunctival closure. That is the most important part. You have to avoid leaks on any end. There are different techniques as for all surgeries, but the closure has to be tight. It can be continuous, it can be wing suture. So this is a wing suture in which you have to be sure that you include the ocular coat, a partly ocular coat with it. So the needle here would be a spatulated atovicral, whereas a limbal suture we usually use a round-bodied atovicral. So we also tend to, with the fornix-based flap, we tend to override the cornea a little bit because there's a little bit of retraction always, and then there is no chance of a limbus exposure. So to summarize, trabeculectomy is a long journey. It starts much before surgery. Judicious preoperative planning and meticulous surgery are the special cares to be taken, and basically avoid hypotony, use antimetabolites, and ensure tight closure at the end of surgery. Thank you for you.
Thank you, Dr. Sushmita. Any questions? So we have time for questions. If you have any, I think we can take them. I think when you're doing the important thing is, from again, why the blebs fail, basically, there are a couple of things. For healing process, you need to have the normal milieu, and that means that your circulation, your nutrition to the tissue should come, should be normal. And because we are doing a lot of cutting there, so we are cutting the vessels, and we are also coagulating the vessels, and we are using mitomycin C on top of it. So what it does is that it actually destroys all the vessels in that area. And most of the time we are thinking in terms of blood vessels, the capillaries, but there are lymphatics as well, and we know there's a lot of work available already there. So we are destroying everything. Now, if you are throwing a lot of fluid into the subconjunctival space, the fluid has to go somewhere. It has to be drained by something. And what we do is that we remove all the draining channels. We are we are cutting down all the draining channels, throwing a lot of fluid there and hoping that this fluid will be taken care of, by some magic. And surprisingly, that magic happens 80% of the time. It works 80% of the time, or let's say 70% of the time. But overall, that's not a normal situation. So the wound, they keep on modulating later on. And that's the reason, because you haven't actually restored the normal physiology. So that physiology is still abnormal, and that's why these wounds, they keep on kind of smoldering, and failure after 1 year, 2 years, 3 years is known. And if you look at the failure rate of TRAB, between 2 to 3 years, 30, 40 of them will fail overall. 30–40% will fail overall. Again, it depends on each patient, so there would be some higher risk and there will be some normal risk patients for failure. I think we'll continue that discussion, but before that, let's have a look at the risks, the factors that could lead to the failure of the trabeculectomy. And then I really also appreciate your own thoughts, how this process of healing or the success of TRAB happens. Yes, please, there's a question.
Sir, I had a question for ma'am. What is the ideal time to release the releasable suture? Because I've noticed after 3 to 4 weeks when I try to release my sutures, it often breaks off and I cannot get it out. Either it is very tight and it is not coming, or is it healing within the layers of the conjunctiva and tenons? I'm not sure.
Yeah, so I don't think anything before 5 to 7 days is of any use if you're putting a releasable, provided of course you've put it tight enough. And but after 14 days, it's a little dicey. But with MMC, we can go up to 3 weeks, but usually after that, it just gets, stuck in the fibrosis. So if you need to take it out, it needs to be before that. After that, if you need to, there has to be, maybe you can do a laser suturolysis. If you have that, you just need a 532 laser to do that. But yeah, you're right. By the time it's 4 weeks, it usually gets stuck and it breaks. Then you have to do something else. But if you want to release it, by 7 to 14 days is the ideal time.
Thank you, ma'am.
I think my thought on releasable suture is like, it helps you, reduce the fluid overload of the tissue right in the beginning. So if you have made them tight and there's not much of fluid going into the space, if that conjunctiva is dry on the first or second day post-operative, that's actually a good situation, because then within 48 to 72 hours, you have enough healing to keep that fluid that bleb from leaking. And then on 3rd or 4th day, you form the bleb. And the bleb can be formed by bleb massage or just a little muscular depression around the bleb without releasing the suture at that point of time. But if some fluid is already going into that subconjunctival space, then you don't have to do basically anything. And then you just have to monitor the bleb. And the monitoring of the bleb would mean that you monitor the height, you monitor the IOP, you monitor the extent of the bleb, and also the vascularization that is happening in that bleb. And your release should somehow be, there's no perfect way of doing it, but I think that can be timed with that. Very often we actually time our release with the IOP increase, but that's good, but I think there are other factors also that we should keep in mind before we decide whether we really want to take out or at what point of time we want to release the sutures. 7 to 14 days is the usual window that we have for releasing the sutures, but I think you have to adjust that according to each case.
Okay, good afternoon. So I'll be talking about the risk factors for glaucoma surgery failure in not just particularly trabeculectomy. We'll just have a peek at what the risk factors have, how they influence the other glaucoma surgeries too. So I'll be picking up from where Professor Kaushik left, that trabeculectomy is a long journey, and for any long journey, we do our preparations of packing and booking our tickets quite well in advance. So looking at your patient when they come to you at baseline, and eventually when they evolve over the treatment of medical therapy and excuse me, until the time you take the decision to do the surgery is very important. And all these gamut of risk factors influence the outcome. It starts right from the beginning when the patient comes to you till that your decision making. So the patient's age, their race, the nature of the glaucoma, any prior ocular surgery, ocular surface disease, the blepharitis, the lid status, the long-term topical anti-glaucoma drugs, and the refractive status in terms of myopia, all of these influence the outcome of trabeculectomy. When we look at preoperative intraocular pressure, the literature is very controversial on this matter. Rather, I couldn't really find a concrete answer to this. There's a questionable influence of preoperative intraocular pressure on the effectiveness and eventual success of the surgery. The high preoperative intraocular pressure levels may be associated with a higher likelihood of surgical failure as per most of the surgeries. The impact, however, may vary depending upon individual patient characteristics, which include other ocular comorbidities in response to prior therapy. And low preoperative intraocular pressure is not an independent risk factor for hypotony post a trabeculectomy surgery. Looking at age, we all know young patients throw up a profuse inflammatory reaction, so there is an increased likelihood of postoperative fibrosis and inflammatory response in these patients, not just in trabeculectomy, but also in trabeculotomy when we talk of congenital glaucomas or in GDD. And there is an increased risk of failure for the first time tubes in younger patients, with almost a 1/3 reduction of failure with each 3-year increase in age. Preoperative medications, we all know, can wreak a havoc on the eye. So anybody who is taking more than 4 drugs or taking multiple medications for over 3 years, or those who have been on oral carbonic anhydrase inhibitors, they are more likely to have a bad course after a trabeculectomy. So we really need to be more watchful for fibrosis in the early postoperative period in such patients. Patients who have been taking long-term prostaglandins have prostaglandin-associated periorbitopathy, which makes the lids quite thick, and that can influence the pressure that these lids put on the blebs that we have created. Preoperative presence of PAP has been shown to worsen the 1-year success rate of TRAB in POAG patients. And it's important that we address this issue well in time, because once we know that subtle signs of PAP have started appearing, it's a good idea to shift your patients, because you want to have an eventual successful outcome of any surgery which you may need to do for these patients in future. Ocular surface disease, although we all know about it, that there is an increased risk of ocular surface disease with multiple medications, and we think that giving preservative-free drugs is a panacea for that, but that's not really the case. Several studies have shown that still there is an element of inflammation at the subconjunctival level whenever the patients are putting multiple medications, because the primary salt of the drug itself is contributory to this. So patients on multiple medications can have Delin post-surgery, as we can see in this patient with post-trabeculectomy. The patient was putting 5 drugs prior to surgery, and the scenario post-trabeculectomy is no better. There is an increased risk of infection after glaucoma surgery in patients with compromised ocular surface. Back-related drugs can definitely make it even more bad for the outcome. The rate of Bleb failure has secondary to subconjunctival fibrosis, and rate of encapsulation of the Bleb has been shown to be as high as 50% at 5 years, which goes up to nearly 60% at around 15 years. So it's a good idea to address your ocular surface disease prior to surgery, and you must prime your patient and tell them that they have to be taking up their drops in, there are many times when we write a preservative drug, but when the patient gets it from the chemist, they get a preservative, the drug with a preservative, because that's relatively inexpensive. So you have to tell your patient when you're prescribing them a preservative-free drug that this may cost a little more, but eventually for the success of an eventual surgery, this is likely to be a contributory positive factor. Delin-like keratopathy not only just exists with post-trabeculectomy, it has also been seen post-implants. This is something that we often ignore. We are so focused at the pressures, the perimetry, the optic disc, that we forget to look at the lid. Meibomian gland dysfunction has been seen in nearly 80% of patients who are using anti-glaucoma drugs. It's really, really important to address this, although it may seem innocuous, but it compromises the post-operative status of a TRAB. The rate of infections in patients with MGD is much, much higher, and giving preoperative doxycycline if somebody has meibomian gland dysfunction can make things a little better. Endophthalmitis after trabeculectomy has also been linked to chronic blepharitis. Now, certain types of glaucoma, by virtue of being more inflammatory in nature, also compromise the post-operative outcome. So uveitic glaucomas, neovascular glaucomas, traumatic glaucoma, and even steroid-induced glaucoma, they may increase the risk of failure post a trabeculectomy. When we talk about steroid-induced glaucoma, this is way more common than we actually see, because in most of the rural and the semi-urban areas, steroids are prescribed right, left, and center, not just by doctors, but also by chemists. So older children or those with long duration of spring catarrh or vernal keratoconjunctivitis, or those taking long duration of steroids with larger cup disc ratios and having a mixed type of steroid use, have been found to be significantly associated with qualified failure of a trabeculectomy. So this is something we need to look. We need to even avert the lids of our younger glaucoma patients, and if they have VKC or any other allergic conjunctivitis, we need to really dig out the history of prior use of steroids in these patients. Prior ocular surgeries also add more trauma to the ocular surface. The postoperative subconjunctival fibrosis after an incisional ophthalmic surgery has been found to be much more, because there is a recruitment of conjunctival fibroblast and inflammatory cells in the local area, and these will get active the moment we do a trabeculectomy. Now, myopia has been cited as a risk factor for causing hypotony maculopathy post-glaucoma filtration surgery, and this is not just limited to trabeculectomy, it extends to tube shunt surgery and even MIGS. So when we are doing myopes, it's a good idea to do a thorough workup and have a plan at hand to prevent postoperative hypotony. Having a higher pressure post the trabeculectomy is not a problem, but we should never go down low on the intraocular pressure. So a tight closure is really warranted in patients who are high myopes. When it comes to surgical technique, we all know that limbus-based conjunctival flaps, especially in younger people, they tend to have a ring of steel formation because of recruitment of inflammatory cells. But these flaps are also more prone to have suture granulomas that may compress the bleb. So most of us have shifted to fornix-based flaps, and we should avoid self-sealing scleral flaps as well. Not only this, the non-compliance with post-operative care, you have taken care of all the factors that I have already talked about, but the patient is not compliant with the post-operative regime, and inflammation is going to take over. Many patients who come from rural areas and they are not able to come for a frequent follow-up in the first week, they tend to miss out on their drugs, and many a times the subtle signs of subconjunctival fibrosis, we are not able to pick it up and address them in time. And so these patients are more likely to have risk of failing bleb. So it is really important that when you are planning surgery and explaining to your patient, to emphasize the fact that in the first 10 days, the follow-up is critical and they may need to come several times, because the early anterior chamber and bleb architecture management is pivotal for the success of the surgery. Now, when we have to stratify and explain to our patient about what outcome to expect from trabeculectomy, it's a good idea to club these risk factors and then prognosticate. So one of the study that was published way back in 2016 showed that if there are no two low risk factors or zero risk factor, the outcome is good. And as the number of risk factors increases, it becomes more difficult to address this. Choroidal detachment, if we talk of a risk factor specific for this complication, high preoperative intraocular pressure, presence of intraocular pressure less than 9 on the first post-op day, male and after penetrating glaucoma surgery more likely. Persistent hypotony is more likely in patients who have had a limbus-based conjunctival flap or a lower preoperative intraocular pressure, and if they've had a choroidal detachment that occurs within the 6 months of performing the surgery. So this was one of my patients who developed postoperative choroidal detachment. At the time of surgery, there was tight closure, the AC was well formed, the bleb was well formed, and it all seemed great. But this patient was a hypertensive patient on oral carbonic anhydrase inhibitors and multiple AGMs. And 2 days post-trabeculectomy, I see a choroidal detachment. Fortunately, the patient responded to AC reformation with Helon, but multiple medications and hypertensive patients are more prone to this. we must look forward for, we must look at the higher preoperative intraocular pressure and hematological abnormalities, because this can make the patient prone to develop decompression retinopathy. Hyphema and choroidal hemorrhage are more common in patients who are on anticoagulation therapy, highest risk being with warfarin, and in patients who have high risk, bridging therapy is really important. This was one of my patients who was on warfarin, although I had stopped it in conjunction with the internist, but the patient eventually did land up with a decompression retinopathy, had vitreous hemorrhage on day 2 after the surgery, which cleared over 3 weeks on its own. Malignant glaucoma is likely with patients who are hyperopes and have shallow anterior chambers. So this is something that we have to be very particular about, because in India we have a lot of patients with primary angle closure glaucoma. And this patient had a malignant glaucoma, and post PPV, the AC is formed both centrally and peripherally. In a nutshell, doing a preoperative homework and prepping the patient well, explaining to them what all can happen and why a meticulous follow-up in the early postoperative period is important, so that we can get a good postoperative outcome. Thank you so much.
Thank you, Parul. Any questions? I think Dr. Parul has covered a lot of things. Yes, please.
So my question is addressed to ma'am. After release of the 2 releasable sutures post trabeculectomy, do you get high IOP, and then do you consider ALS for the last remaining flap, remaining suture on the flap? And what is the ideal timing for the ALS in these cases?
No, you mean you've removed the releasable
Yes.
and the pressure is still high?
Yeah.
Yeah, so most likely that will be because the scleral flap has probably started fibrosing down, and it's unlikely that removing even more will help. You'll probably need to needle it or do something to revise that bleb, I would think, that once it's out. And like Dr. Pandav said, 7 to 14 weeks is the time when it would. Try a massage. Even if that doesn't work, then maybe you'll have to resort to a needling or something. And doing a laser suturolysis of a second suture after removing the first rarely actually works too well.
You have to look at that way. So you have released 1 or 2 sutures, and after that, is the bleb formed or not?
Yes, the bleb is forming on massage.
So that's very critical. So if the bleb is not formed, so that means problem is not, that means the suture, release of suture has not actually worked, so the flap is already stuck. So you have to find some way to elevate that. In the early post-operative period, even the bleb massage could do, or the differential that you depress on the lip of the sclera adjacent to the incision line, and that can open, that can fish mouth it, and the fluid can come out. Or you make sure that the ostium is not blocked. So you have to do gonioscopy and see.
So basically, the ostium is not blocked, the massage is working, but
now,
it's the sutures
so
that
now
tight.
we have released the suture, and there's a fluid under the conjunctiva and the tenons, right?
Yes.
So there's a fluid there.
Yes.
So releasing extra suture will not work, because the fluid is already coming into that place. Because the primary objective of the release of suture is to make sure that the bleb area communicates with the anterior chamber, and that you have already established automatically or by after releasing the 1 or 2 of the sutures. Now the pressure is high. So the problem now is that because their bleb is not functioning well, right? So what could that be? That means your bleb is actually getting localized perhaps. So because now that fluid that I mentioned earlier, now you had dumped fluid into the subconjunctival space, but there's no way that this fluid will go into where it should go. So it's getting stagnant, it's getting tapped there. So best thing is, in the early post-op period, you try to take that fluid out of that small area. And Dr. Sushmita mentioned that you massage those blebs. In the early post-operative period, when the fibrovascular tissue is still forming, you can actually create, some, with the massage, directly onto the bleb. You can, push that fluid in the adjacent tissue, and you can create some gaps in the fibrosis which is happening. So don't let that ring of steel form, and then you kind of try to get those blebs flatter, because at this point of time the IOP will go up, then the bleb will start becoming more prominent, and it will be local. It might gain in height, there might be vascularity. So Other thing would be at that point to look at would be how the vascularity is happening in the bleb. So diffuse the bleb, give massage, and if it's becoming like this, you see there's a more vascularization of the bleb, and that might be the time when you could supplement your antimetabolite. So you could give 5-fluorouracil injection in the post-operative period to supplement if you are given on table, or if you're not given on table, then you do that now. So at that point, I think your emphasis should be to get that fluid out of that limited area, and the best thing to do would be to cut down the inflammation. You might use antimitotic if required, but best thing would be to massage that bleb and let that fluid go out of that. Don't let that fluid get trapped into a small area. If it gets trapped in the small area, then that gets further localized. And after that, releasing suture or laser suture lysis will not work. And after that, only needling would be the option left. So as Dr. Surinder mentioned.
Okay. So, sir, how long we can observe these patients on high IOP, say around 24, with massage only?
I think you have to see whether it's working or not. You keep the pressure low with anti-glaucoma medicine, adjust your anti-inflammatory and other things, and keep massaging this bleb, and I think bleb massage works even later. So it depends whether you are succeeding or not. So after bleb massage, if you can see, you can actually see the fluid going in the slit lab. You can see the fluid, going around.
And the IOP also drops.
And IOP also drops. If that's happening, so keep doing it as long as that's happening. But when that stops happening, that means now you have gone beyond the recovery point. So you have to take some other measure. Thank you.
Excuse me.
I
I
have
have
two
a
questions.
question with the.
Yeah, please carry on. I have two questions. One is that do you always do trabeculectomy with antifibrotics, or you customize? Always.
Always.
So even if it's a virgin case also you try with this?
Yes.
Patients whom you think like this?
I would only possibly modulate the concentration, maybe in an absolutely virgin conjunctiva 0.02, but I've shifted to 0.04 in most. So most of our trabs are virgin conjunctiva. It's the first surgery that they're doing.
And always MMC or 5 if you consider?
No, on table MMC, but post-operatively if we
Injections.
need it, then 5 milligram.
Thanks. Another thing is, in some of my patients, one eye, high myop, of course, one eye showed hypotony. Hypotonous maculopathy, not only hypotony, hypotonous maculopathy. So other eye also needs the trabeculectomy. What could be the precautions and
Lower MMC, lower concentration because they are very thin stretch scleras. But if the glaucoma is not too bad, try a MIGS. I mean, try something without having to cut open sclera. And
but
open
I'm not
conjunctiva.
very confident about MIGS.
Yeah,
so
I mean,
far.
I'm just saying if it is a mild or moderate case which is not being, so sometimes that helps. But I suppose tight suturing, viscoelastic intraoperatively, avoid hypotony, and lower the dose of MMC.
Or not at all, don't use something.
Not at all is, I don't know, it somehow never works. I don't do not at all. I would always use MMC.
Yeah, but if you have more concerns, I think you can avoid using that. You can do it post-operatively.
Post-operative injection, 5
You
FU.
could 5-fluorouracil post-operatively.
Thank you.
Yeah, some more questions, please keep, yeah, yes please.
My question is about this early bleb failure. Like the previous question, after suture lysis, the bleb has still not raised, pressures are high. So suspecting fibrosis subconjunctival or at subscleral level. So for a young glaucoma surgeon, ma'am, can you tell the step-by-step method of bleb needling with antimetabolite? Like what is your preferred needle used, what gauge, and preferred antimetabolite used?
I'll show you the
I
bleb.
think Sir's
I'll show
talk
you a
is that
video,
only,
bleb
yes.
needling video I'll show you,
Yeah.
okay.
So I think that's a stock.
And
to-
we can, I'll finish my talk and then we'll come back to, this issue again if you have any question. Can you give me my slides, please? Okay, so once the Bleb is failed, what are the options that we have? It is the most successful procedure, but still, as we have discussed, the failures do happen. And trabeculectomy is very labor-intensive job. So the job, it doesn't finish with the surgery. And in this one of the studies, if you look at 78% of these cases post-operative, they needed some kind of a Bleb management, Bleb manipulation in the post-operative period. And and the Bleb massage is very important, and half of them would need it early or even late. But Bleb massage is usually useful only in the early post-operative period, starting from day 1 to perhaps 1 or 2 weeks, and after that its utility gradually goes down. Suture removal, we are using, most of the trabs are now with the releasable sutures, so I think suture removal is required again very often, almost half of them. If you have suture tight enough, then actually all of them should need suture removal, but I think even after tight suturing, some fluid still goes into the subconjunctival space, so it's not a watertight closure always. So that's the reason half of them will still filter without releasing the suture, but that's another common procedure which is required. And also supplement of 5-fluorouracil might be needed, and then of course we need needling for some of these Blebs, which is again almost 20-25% of the cases we need that. In spite of that, the failure rate is quite significant, and all that you have done, all the manipulations, and still over a period of 3 times, or I would say within 1 to 3 years, 1/3 of your traps, they are likely to fail, or they will need something extra. So what are the options to salvage these Blebs? As we have been discussing, it's important to look at the tissue, the Bleb, very carefully, and try to ascertain what is the likely cause in that particular Bleb which is leading to failure. Is the conjunctiva quite healthy, mobile, intact, or there's a fibrosis there, or a vascularization there, or there's a inflammation which is still going on? So that we need to ascertain, because next step would depend on that. We also need to check the ostium that we have created, the trabeculectomy fistula, and that should be patent. And then we also try to ascertain what is happening to the skull flap. It is visible, it's not visible. Is there a big scar tissue there? Is kind of a tether to the scalar bed, or it is elevated? And at this stage, you could also do a AIOC2024 or UVM to see whether there's a fluid pocket underneath the Bleb or in that area or not. So if there's a fluid pocket there, that means that there's a communication which is between the anterior chamber and the Bleb is maintained. And it's basically the fibrosis which is causing the trouble. So if the conjunctiva is healthy and you have a fluid underneath there and the ostium is patent, I think what you can do is you could consider trabeculectomy needling in those cases. So this is 29-year-old female, both eyes GOAG, one-eyed, advanced glaucoma with almost total cupping, and right eye mitomycin C was done some years ago. The Bleb was nice, diffuse, and controlled pressure for almost 3 years before it started rising, and then we had anti-glaucoma medicines, and the pressure kept on. Was not controlled, and it was progressing. So you can see the pressure is about 23 with the oral Dimox and acetazolamide and 4 topical. So you can't really go beyond that. So what we did was, you can see the Bleb area is, the conjunctiva looks okay. There's a fibrosis, there's no Bleb there, the ostium was patent. So this was a patient 4 basically. So what we do in the needling, so we decided to do needling. So this, what I'm injecting is actually local anesthetic. So this is under topical anesthesia, so I haven't given any retrovalvar. And after you inject the local anesthetic in the subtenon space, then you mobilize. So what I'm doing is I'm using that local anesthetic as a hydrodissection and to mobilize the tissue. And then you go posteriorly with the bent needle, 26 gauge needle, and now I am actually cutting that fibrous tissue which is there in that Bleb area. So I'm going, entry point is quite away from the limbus because I don't want that area to leak. And then you just gradually you cut that tissue with the sweeping motions. And now you also monitor the IOP, and some point of time the IOP will go down, and your bleb, now you can see the bleb has started forming again, is increasing. Now you can see the bleb is increased. And because if you leave this bleb, the eye becomes hypotonic. So if you on table, if you see the eye pressure is too low, then you can create a paracentesis and inject some fluid till don't leave the eye grossly hypotonic. And that's it basically. And you could inject 5-fluorouracil on the same day in the adjacent area, or you can use 5-uracil in the postoperative period. So this is how this bleb behaved. This was the 1 week after surgery. You have a diffused bleb and the AC is nicely formed. And 3 months later, the IOP is 10 millimeters of mercury again, and vision is maintained. So bleb needling is a good procedure for the failed trabeculectomy blebs. And as you can see in this study, 5 FU augmented bleb needling within 1 year, one year of trap can lower IOP more than 20%, and that is a lasting effect and could last for up to 2 to 3 years again. So practically, you are re-establish filtration in these bleb using. The other method could be that you could do a trabeculectomy which can be redone in the same eye. So this is 57 years old female, angle closure glaucoma. Both eyes trabeculectomy was done in 2007. There was a diffuse filtering bleb for 14 years, and after 14 years, the bleb starts scarring, and actually it fails, and IOP is high, the visual start progressing. And we tried needling first in this patient, but that kind of failed. And then we have, you can see the IOP is high in this with multiple drugs. You have 6/9 visual acuity, and this is what we did for this patient. So we revised this bleb, and you can see this is the normal procedure here. So what you do is basically I have opened up that tissue there, and this is the old trabeculectomy site which has opened up, identified the previous the area of the bleb, and then you like you do trabeculectomy, you just open up mostly with a blunt dissection. You would be able to identify the edge of the flap and then just open it up. And once you achieve that, you could put a couple of sutures if required in that area and close it like it was if any other trabeculectomy was done. So once you had opened it up, you could do that. Now once open, now it starts flowing, and then you just close it like any other trabeculectomy. And this is the post-operative period, because the new flap that we have created is the old flap basically, which may not be as smooth as for the old one. So you could get some extra leakage from that point, and the IOP is a little on the lower side, and bleb is a little flat. But this has been tried earlier also, and you can see the posterior revision of the bleb can have long-term outcomes, and 80% of the cases it would be successful and without any requiring anti-glaucoma medicine. So this is another viable procedure. The other procedure we do is the bleb revision through an external keyhole incision, and again, this is a 55-year-old male POAG patient. 2 years, TRAV was done 2 years back, and you can see it's doing very well, except that the bleb has now failed, and your UBM shows that the trabeculectomy site is patent there, but you have that fibrosis around it, and you have the clinical picture there. So what we do here is that you can create a small opening in the posteriorly. Now this is the failed bleb, so I'm going a little more posteriorly. And you make a small keyhole incision, and that through keyhole incision you dissect mostly with the blunt dissection, just by the opening action of the scissors. And just mobilize that tissue, and once you have mobilized that tissue enough, you create pockets on either side. Oh, it's not moving. Okay, you can create pockets on the either side basically. And now the video stopped working. Okay, I'll just show you this video and then we'll stop. We have 5 minutes, I guess. So I'll let this video play, and then we'll close. So just keep opening, the tissue. So just mobilize the tissue. I'm basically trying to go under the scar. So there's a scar tissue there. So I'm not actually excising the scar. I'm just going on the scleral plane. And now you can mobilize on both the sides. So this is kind of beyond the posterior edge of the flap, and then you have to put some mitomycin C like you do for other traps. And after you have done the mitomycin C application, wait for 2 minutes or 3 minutes, whatever the time frame that you had chosen. Have access to the anterior chamber through paracentesis. Remove the mitomycin C and wash off that area. And now this section is carried out further. Now you'll see that you are going under the flap just by the opening action of the scissors. And at some point you will see the aqueous egress. Now you can see the aqueous is coming in that area. And you can actually enlarge that a little bit more. And then inject fluid through the side port, and you can see the fluid is coming into that incision. Now once that happens, you don't have to do anything, just close the wound and procedure is done. And this is in the post-operative period, you could see the AC is nicely formed, you have a bleb there, and the pressure is controlled. And this is after follow-up of 3 months, you have a nice bleb and the pressure is well controlled. But if you have a situation like then when the bleb is totally scarred, then you have no actually option of revising the bleb. The best would be to just excise this bleb and put a skull patch graft and to secure basically to make the eyes safe, and later on do it, you could do tube surgery in these eyes. So if everything fails, then basically you have the tube surgery will come to your rescue. So in summary, trap failures are common, and a number of options are available. Each of various interventions have a specific role, and it depends on the situation at hand that which role, what you will do. And there's no procedure which is perfect, and it's possible to revive failed blebs in most cases. And however, the success rate of the retrap is lower than the prime trap. And GDD play an important role here. And thank you very much. Thank you very much, all of you. If you have any questions, you can email it to us, or you can ask later, because I think the next session is starting, and we already have people. So, sorry for overstepping a little bit. Okay, thank you so much. So we finished in time. Thank you so much.